Hello, I introduced myself earlier, but in case anyone wasn't here, I'm Dr. Vicky Joshi. I'm a research fellow at Glasgow Caledonian University, and I kind of look after the South Recovery Group. Now, South Recovery wouldn't exist without all of the amazing work that you do, because we wouldn't have any survivors to be thinking about. So I think South Recovery, by the sounds of it, all these amazing projects and things that are coming, hopefully what we're going to have is more work to do in the future, because we're going to have more survivors. I'm just going to give you a little kind of update on some of the things we've been doing in the last year, and a little reminder about what we do in South Recovery and who we're interested in. So survivors, really obviously. If you've heard me talk before, I'm listening to Ron and he's talking about the 22-year-old that was discharged and everything's great, and I'm thinking, ooh, I wonder how his brain is. I wonder how he's feeling. I wonder what he's thinking about having an ICD now. I wonder what he's thinking about having all these shocks or not having a diagnosis. I'm also wondering, who did the CPR? What were his family thinking? You know, how do they feel? They were maybe, again, how does it feel to have a family member that doesn't have a diagnosis? You know, fear for the future. So we're thinking about the survivors, we're thinking about the family members, bystanders as well. And of course, because we have many more people, unfortunately, that don't survive, we often have many more bystanders who've done CPR where the person hasn't lived. And then they're not in contact with any kind of services afterwards. So we maybe have many more bystanders than we do have survivors. On that list also is volunteer responders. So CFR, I've talked to so many of you today, and it's amazing. And thank you so much to Lisa and the Newtons to really highlight the work of that. But that's a group that we need to be thinking about as well, I think, in South Recovery. And then we have the healthcare professionals, the EMS, you guys. And again, it's not something we've done a lot on yet, but we are aware, particularly maybe when you are maybe involved in events or doing CPR outside of your normal role or outside of your normal working hours. Of course, we're all willing to step up, but actually looking after you afterwards. So what have we been doing? Well, quite a lot around information. So something I often say is, if you've had a stroke, nobody's surprised that you might have something wrong with your brain, or you might need support or rehabilitation afterwards, but it's not something that's commonly known after cardiac arrest. So we've been working really closely with the Resuscitation Council to produce new information that we're hoping. This is a really simple leaflet. It's really just giving the beginnings of information and some signposting, hoping to get that into the hands of every cardiac arrest survivor and their family members. We've also got new resources on the NHS Inform website. So again, one place where people can go, get all the information, and then the signposting to other organisations. If you are interested in getting the leaflets, you can follow that QR code, and I think they are free, and they're certainly free to download, but the paper ones, I think, just paying for postage and packaging. So, and then that's the QR code that will take you to the NHS Inform website. Research, also vital. I would say that we are still quite a long way behind in terms of other kind of long-term conditions. In terms of cardiac arrest, we still have a lot of gaps in our knowledge about what the key priorities are for cardiac arrest survivors and how we can deliver aftercare. So I'm very pleased to say we've been funded for a 3-year research project funded by the Scottish Government called Carousel. I know, I do like to name things and have nice logos. I could talk all day about what we're going to do with the Carousel project, but at the heart of it are a series of studies that will tell us who our survivors are in Scotland, where do they go. We're going to follow them through using the SCAS out-of-hospital cardiac arrest data. We're going to follow them through the routinely collected health data. Where do they go? How long are they there for? Who are they coming into contact with? We're then going to follow a group of survivors and their family members in a quite in-depth way through questionnaires and through interviews at 4 time points after their cardiac arrest, up to a year post-cardiac arrest. The idea being that we can really then identify what are the unmet needs, where should our intervention be, who should be delivering it, and what are the priorities. So at the end of it, we're going to be doing some work with clinicians, people like yourselves, to then design this aftercare intervention. And also think about What's it going to cost? Who's going to deliver it? How are we going to implement it? Just thinking about bystanders, I can't stand here and not talk about the bystander advice line. We're so lucky that Chest, Heart and Stroke Scotland support this. Hopefully you've all seen these pink cards. These are the pink cards that are hopefully given out at the scene of a cardiac arrest. I know there's been a new project that Shorty's been delivering for the cards to actually sit in the drug pouches. So the idea is when you open them up, they almost kind of pop out or fall out. We know there's a lot going on at the scene, so we do really appreciate the fact that you are giving these cards out. We know that they're being given out because that's the main way that people are coming through the advice line. We've had 308 contacts, mostly telephone calls, since I think it's about 2.5 years that the project's been running. And what we're also seeing is a year-on-year increase in the number of contacts, the number of calls as well. So we are 27% up on the last year to the previous year. And again, so much of that is to do with the promotion, all right? Again, it's not common knowledge that if you do CPR, if you're a bystander, that you might actually need someone to talk to afterwards. So half the work with this project is getting that message out there. Again, what are we doing next? What are we thinking in terms of bystanders? We met last week at the race meeting, another natty name and logo, I know. Recovery after cardiac arrest, again supported by Chest, Heart and Stroke Scotland. All the people that you see there are really passionate about bystander aftercare, looking after the people who stepped up and done CPR. Some of the things that we're thinking about is what can we do at each stage of the chain of survival to reduce the impact on bystanders? Not affect survival, but are there things that we could be doing to just reduce that impact on bystanders? Access to information, communication and support, and the right support at the right time. So something we hear from bystanders is they do want to talk to someone, and we recommend that they talk to someone, but it can be pretty tough having that conversation with a friend or family member or co-worker. So having somebody independent to talk to through something like the CHSS advice line seems to be really important. One of the other things we're thinking about is when we talk to bystanders, can that help inform what we're doing at the beginning of the chain and thinking about the way that we teach CPR? So that's a bigger project that we have ongoing. So I'll come back to my first slide. I would say that we're doing okay on the survivors. Okay, there's still a lot to do, but we've made some good inroads. Again, family members, that kind of goes hand in hand. And we are making some good inroads with the bystanders. But I will be honest, South Recovery is a very small team, and we haven't really started looking at volunteer responders and healthcare professionals. So what I would say is there is lots and lots to do. So if you are interested in any of the things that I've been talking about, please do get in touch. There are lots of questions to answer and lots of, I think, quite simple ways that we can be solving some of these problems. So please do get in touch, even if it's just a case of you want to maybe offer your expertise or your experience, maybe be involved in a focus group or something like that, or you're actually thinking, I'd quite like to get involved in the research. Okay, I'm going to stop there. Oh, I forgot to say, these are just some of the groups and institutions that help out with South Recovery, and I'm really glad that Chest, Heart and Stroke Scotland and Sudden Cardiac Arrest UK were here today as well, so a big shout out to them. Right, Smita? Lisa.
Got 8 small minutes to talk to you about this. But I want you just to think a little bit about why you do what you do when it comes to out-of-hospital cardiac arrest. What's your passion? Well, mine really is about working with people and working with communities to be able to empower them to actually take stuff into their own hands and make things work in their own communities. And actually, if I dig down a bit deeper, the stuff that really gets me passionate is about those people who we know already are still at the sharp end when it comes to survival from out-of-hospital cardiac arrests. And they're the people who live in the areas of deprivation in our beautiful country that is Scotland. So let me just dive in and ask you this question. If Scotland already has thousands of pads, why are those living in deprived communities still less likely to use them? We heard Andy talk at the top of the day about the great stuff, the strategy that we already have in Scotland. We've got data, we've got the strategy, we've got Save a Life for Scotland, we've got Good Sam, we've got the circuit, we've got CPR and DFib training in schools, and we've got Scottish Government support in terms of funding, who want us to be able to put DFibs in deprived areas, those areas that really need them. So we seem to have the system in place, but it just doesn't seem to be completely working for everyone. If we've got the system, why aren't people who are living in areas of deprivation using pads, and why don't they feel ready to use them? So I've taken a little bit of time out just to do a little bit of a deeper dive into the literature that kind of sits around pad use. So not even just looking at deprived communities, but really, why do people use pads and why don't they? What puts them off? And if people have tried to get people to use pads more, what have they tried to do? What worked and what didn't work? And it's been really interesting. When we look at Scotland's data, the feeling is, or if we don't look at Scotland's data, the feeling is actually, if there's more cardiac arrests in deprived areas, let's just give them more pads. But when we look at Scotland's data, there's a similar amount of pads in SIMD1, the most deprived areas, as there is in SIMD5, the most affluent. So it doesn't really seem to be about the fact that they don't have enough pads. It seems to be that there's still this gap in outcomes, and it might actually be about readiness rather than numbers. So we really need to know why they're not engaging equally. So looking at the research, when we look specifically at barriers, none of this will come as a surprise to you. Across numerous countries, numerous contexts, numerous communities, there's three main things that come out of it that are big barriers, and they're not technical, they're human. First really is about self-efficacy, and what that really means is, have I got the confidence to do it? Am I the right person? And we see this in CPR as well, people who just step back and think, actually, there must be somebody who's much better at this than I am, so I'll let them do it. And the second is fear, and we all know what that feels like. That fear of harm, of judgment, of legal consequences, that fear that we might look stupid in front of other people who are there. And then you have legitimacy, which is slightly different from self-efficacy. It's that I want to do something, but actually, am I allowed to do it? Is there something in that environment or the people around about that's putting them off? And when you look across these studies, what's really interesting is that there's this consistent thing, that when you look at people who live in areas of deprivation, the fear, the lack of confidence, and the lack of that feeling that they've got authority to do something is consistently higher. And that's really people who have got less educational attainment, people who feel that they've got less social power, and people who've got less training. So we're all in the same boat. These problems are just harder for people who live in deprived areas. And as I looked more at the data and at the papers, I realized it wasn't just like human barriers. We have some real structural barriers, and you know this already. Defibs in cupboards, getting dusty, behind desks, locked away in boxes outside, inaccessible 24 hours a day. An invisible pad, to me, is almost the same as no pad at all. So on top of these human factors, we've also got these real structural factors. But physical invisibility and social invisibility are two separate things. So you can kind of fix physical invisibility. You can put a sign on the wall. You can take that pad out the cupboard and you can put it in a box outside. But social invisibility, you can't fix with a sign. You could say a sign that says, please use this is yours to use, but we don't do that, we just say it's a defib. So what interventions have people tried across the world? Well, I just want to share 3 examples with you. The first was in Singapore, and they have used a smartphone responder system and put lots of pads out. Did a bit of mass marketing, and they have increased their pad use 4-fold. Another really interesting study, slightly controversial, in Italy, this project's been running for 23 years. And instead of teaching people how to do CPR, they teach them how to use a defib. And they have about 150,000 volunteers, loads of defibs, and their ambition is to get pinged by a smartphone, get the defib, take it to the person, and shock them in under 5 minutes. And they don't do any CPR at all. They've got a 46% survival rate in that area. They've taken the fear and the whole technicality of chest compressions out of the equation for lay members of the community. Controversial, but something to think about. And then in Denmark, well, Denmark, we know, just like throw the whole kitchen sink at stuff. So they used mass marketing. They trained loads of people. They put loads of defibs out. And over a whole year, the people that they trained in their communities had a real increase in willingness to use a defib on somebody, and especially a stranger. The things that worked, well, when you just put defibs out and give people information but don't engage with them, they don't work that well. It's not rocket science. If you engage communities, talk to them, find solutions with them, then those interventions are much more likely to work. But the thing that stuck out for me from all of this is this just huge lack of studies and interventions that have not been done in deprived communities, where we know that cardiac arrests happen the most. They're all just generalised. And there's hardly any studies or work that's been done that's been co-produced with communities who are most at risk. From this work, we know what works, but we don't know if it works equitably. And we don't know how to make it work equitably. So we might be really good at building pad infrastructure, but we don't fully understand how to build pad readiness for the communities that need it most. And we've got a responsibility as people who care about this stuff to make sure that the communities that need it most get the most attention around this. And I think it's not rocket science. The people in these communities know what it feels like to be in an emergency situation. They know what it feels like to feel unsafe. They also have solutions, but they also know what kind of words, what kind of methods we use that will completely put them off. So it's really important that we're the ones who sit down with them, share this information, tell them what the outcomes are for their communities, give them some options of what's tried before, and work with them. Because a pad doesn't save a life, a person does. And the people who live in deprived communities are the same as us. It's just that learning how to use a defibrillator is not top of their to-do list for that day. People are dying in these communities who do not need to die. And we've got a good system. But whether that person acts in that time, in that community, in that emergency, will depend on whether the system was ever really built for them. So my challenge to all of us today is, let's sit down with them. Let's co-design and produce a system that works for them. Thank you.